Hello, everyone. Welcome, and thank you for joining the 24th webinar in our Pandemics and Society series. Today's webinar topic is titled, What's at Stake? The Impact of U.S. Cuts to CDC's Global Health Programs. I'll now pass it to our moderator, Jennifer Nuzzo, the Director for the Pandemic Center at the Brown University School of Public Health, to begin today's conversation. Jennifer?
Hello, all, and welcome to our discussion today. The United States has been a key supporter of global programs that help prevent, detect, and respond swiftly to infectious disease threats abroad in order to prevent such threats from spreading to the United States and elsewhere. This year's recent U.S. budget proposals aims to slash budgets for most global health programs run by U.S. CDC, programs that have enabled the swift containment of deadly disease outbreaks abroad. It would also eliminate a number of critical programs focusing on global HIV/AIDS, tuberculosis, immunizations, and others. And these cuts aren't happening in a vacuum. They're also coming alongside with recent administration's dismantling of the U.S. Agency for International Development and an executive order to withdraw from the World Health Organization. So lots of a change happening at once. And with so much change, we want to understand what it will mean for disease threats and particularly what they pose to American health, security, and prosperity. We have a lot to discuss, but today we're going to try to focus our conversation around the projected impacts of shuttering of key CDC programs such as the Global Health Center. And specifically, we want to know how this will affect America's ability to secure a healthy future and protect the people within the United States borders from disease. What does shrinking engagement in global health mean for U.S. interests? And today, to help us sort of unpack this and understand it, we have two incredibly experienced panelists. First, I'd like to welcome Jennifer Cates, who is the Senior Vice President and the Director of Global Health and HIV Policy at KFF, a leading policy organization in the United States. And we're also joined today by Rebecca Martin, who is Vice President for Global Health and Director of Emory's Global Health Institute at the university. Rebecca is also the former Director of CDC Center for Global Health. So thank you both for joining us today. We want to get to your questions, and so please do feel free to use the Q&A function to start asking them. We will get to them. But first, I wanted to kind of kick off the conversation with just a few kind of orienting questions. So let's dig in. And maybe I'll turn to you first, Rebecca, since you have the firsthand experience with these the programs run by the CDC Global Health Center. Can you tell us a bit more about CDC's global footprint? What does it do in other countries in terms of controlling and containing deadly disease outbreaks? I think a lot of people, when they hear programs, they don't necessarily know what it translates to in terms of functions and sort of benefits for the United States.
Thank you, Jennifer, for that. And I'm going to be a little bit longer on this question because I do want to give a little bit of a background too about why the CDC was formed to begin with as well. And it was founded to control malaria. And I think that's really over the decades, what has been done to prevent and control diseases and to build on that has always been at the essence of what CDC is. It is there to protect the health, the safety, and security of Americans by stopping threats at their sources before reaching our borders. And I want to give two specific examples of having been in countries meeting with the U.S. ambassador to the Democratic Republic of Congo, who told me in a meeting, I have my regional security office, which does my security, intelligence information that I need, and I have my CDC team for health security, for outbreak response, and both are important in the diplomacy of what the U.S. Department of State does. And then having gone to Rwanda to meet the U.S. ambassador, told me we were working there to build health capacity, working with U.S. government. And he said, this is so important to me that I can deliver important messages on what we're doing and how we're collaborating with countries, because it allows him to build relationships with the host government, as he also has to deliver very tough messages to the governments as well. But it allows the connection of all of this work on multiple facets across different sectors. So I want to give those as examples of why it's important to have CDC globally and what the value is to the US government, to the US people, working through global health security to strengthen the laboratories, disease surveillance, emergency response systems, and the workforce through the field epidemiology training program. All of these are, in essence, to build capacity, sustainable capacity in countries so that they can respond to their own outbreaks. And we've seen this happen over the years where there's been many success stories where diseases have been stopped and not spread because of this capacity that's been built. And then thinking a little bit within the US foreign policy goals, we know health security is national security. We saw this through COVID, the importance of the commerce and trade and travel, and the value of partnering with other countries and being able to look at this from a national security perspective and standpoint. And on that, well, falls the World Health Organization and the critical relationship that has been happening with CDC being able to be embedded within WHO, and that what that allows us is to be able to set global strategy, to set standards, and to make sure that we've been able to have policies that help and protect Americans here in the United States and abroad. And then lastly, I will wrap up on this point, but it is also the opportunity that we can advance both bidirectional science and innovation. We learn about threats, Zika, chikungunya, Ebola, and we're able to develop medical countermeasures, vaccines and treatments. But many of those studies could not be done here in the United States. They have to be done in other countries, but we need the vaccines. We need the antiretrovirals, that we need them here because we need to protect our populations. And we can't do them here because it's too small of a population to do the science. So we need that to be able to have access to those to help and protect our citizens. So I'll stop there, but thank you.
Yeah, thank you for that. Maybe I'll turn to you, Jen. I know you've been tracking some of the other programs, things that are not just solely in the purview of CDC, but certainly that CDC is involved with, things like PEPFAR. And I want to raise this because often when we're talking about programs, sometimes we talk about global health security as sort of separate from other global health initiatives. But that's really, I think, a kind of artificial distinction. I'm wondering if you could talk to us a little bit about how these programs that may have been set up for disease-specific purposes get used for other types of situations, including, public health emergencies, things that the global health security community often thinks about.
Yeah, thanks, and good to be here. It's actually a really critical point. So the U.S. government has operated many global health programs around the world, and it has been the largest until recently, largest donor, implementer, technical expert on a whole range of global health issues through its disease detectives at CDC, which I want to come back to that. And then, of course, PEPFAR, which is the global AIDS program of the U.S. government, which is like the flagship global health program. And now that program set up by George W. Bush was set up by design in many ways like a very vertical program. It's going to be focused on HIV, and that's been its, one of the things that's really driven it and why it's had a lot of immediate success and continues to have success. However, what is less known is that the way in which PEPFAR works is to engage. Let's say actually CDC implements half of PEPFAR. So even though it's a global program that the State Department runs, CDC is one of two agencies that has been implementing most of PEPFAR. And the way in which the U.S. government has done that is to work with other health ministries, with clinics, with hospitals, with community organizations to build and create labs, enhance lab infrastructure, enhance surveillance, and really invest in health systems, because back when PEPFAR was created, the health systems in many of the countries in which it went to work were much weaker, and PEPFAR couldn't just kind of go in and say, here's HIV drugs, had to kind of set up systems. So what has happened over years is that those systems have become more robust and had a real impact actually beyond HIV. And there's been evidence from Ebola outbreaks, from other outbreaks, that the investments that CDC and the investments that USAID and state have made through PEPFAR in HIV, just to respond to HIV, have had these spillover effects and actually helped to strengthen and protect other countries when there were other kinds of outbreaks, which of course helps us in the United States. So, I think that's just a really critical point. And just picking up on some things that Rebecca said, I know most Americans probably aren't aware that if there's any outbreak in another country, particularly a lower middle income country, one of the first calls made is to CDC. We don't hear about those. We don't know about those, and that's by design. When public health is going well, the average person in a community is not going to know that there's something to worry about, because CDC is protecting the waters, protecting, the air, all of the things that you do when you're an epidemiologist and you're trying to surveil and try to understand. That literally happens around the world. And so dismantling that or clawing it back to some degree will affect that system. And I think that's the thing that we should all be worried about. The whole goal here is to keep pathogens out of the United States that aren't here or are typically here. Thanks.
Yeah, thank you. I want to kind of reiterate that last point in particular about, when there's a problem in the world, people pick up the phone and call CDC. I mean, it's also the case that if you look at around the world and you look at other countries, similar agencies, Center for Disease Controls, there's a good chance that the US CDC helped establish that, helped provide the technical assistance, the bureaucratic assistance, the administrative assistance to make those agencies important. And there's often an exchange of sort of scientific, scientific exchange so that they continually learn from each other. I don't think people realize how much work CDC has done around the world. And I was struck by, a number of the countries that had celebrated responses to COVID, countries that were sort of highlighted for doing really innovative things. It was often their CDCs that were set up by our CDC that led those efforts. So really important. One of the things I'm also struck by is since January, the change of administration, there has been a really staggering number of health emergencies around the world. We're in the midst of the second Mpox public health emergency. There have been multiple outbreaks of viral hemorrhagic fevers. Really, the number of disease threats that people are watching with worry that have been in some cases contained, but in other cases still going, is truly staggering. And yet, at the same time, there's been a tremendous amount of upheaval in terms of the overall infrastructure and funding for programs that are going to be necessary for detecting and responding to those sorts of events in the future. So maybe to pose the question to the both of you, where are we currently with respect to global health programs, particularly around this topic of preventing, detecting, and responding? What are you seeing now in terms of changes, and what are your biggest concerns in terms of changes in the near and long-term future? Maybe I'll turn back to you, Rebecca, if you have any insights.
Thanks, Jennifer. And this is a really important issue because you're right. Outbreaks are not going to stop. Diseases are not going to stop crossing borders. So it is, what are we going to do about it and how can we do it? And there have been changes that we've seen. I just wanted to build off one thing that Jen mentioned as well, which is, the whole PEPFAR. I mean, all of that does fit into the whole health security. I mean, it was started as an emergency response. And as well, if we even go back further with polio eradication set up all the biosecurity protocols and standards and is now leading the way for thinking about containment of another virus, the only one after smallpox. So I think these are really important things that have been there. Where we go from here, as you asked some of the questions, there are some real threats. I mean, as we're seeing the impact on CDC hiring freeze. So we're thinking now there's, when people on positions that are not permanent, they're leaving positions. So there are some countries where there's been a loss of technical support and expertise. We've seen reductions in force at the country level where there's been building capacity, working with the laboratories, and they're not able to partner with the countries. But I think one thing that Jen said, which is the most important too, is this relationship that takes decades to build and sharing of information about knowing about, hey, we're seeing this new virus, we're seeing this new outbreak, what is this? But that, so we can think about how we as the United States would get prepared, what can we do to support and build that capacity? And that conversation is going to get lost, especially when there are not people in country anymore to have that conversation with. These are things that are normally not done through channels that are public, but done through the relationships that have been built and wanting to share specimens, sharing information. So we will lose ground on being able to know what's out there in the world circulating, what's the critical threats. We're seeing this in many different things that could happen and outbreaks that could occur. I do think, as well as Jen mentioned, the success that we've seen with PEPFAR, and she mentioned, I mean, the CDC delivers over 60% of treatment. Success will be lost at this risk, and we'll see these opportunities for backsliding on some of the progress that's been made, and through the relationships. While I do and fully recognize capacity has been built because it's done through country building capacity, but those relationships that allow the information exchange and having new evolved relationships where you're now talking about how to partner on technical innovation and how to think about the next level, those won't happen anymore. And that's where we'll be at a loss of what we'll know what's coming.
Yeah, and I'm struck by a bit ago how there was a day when I remember the US was closing an embassy abroad and bringing back Americans who were involved in that. There was a security issue around the embassy, and there was also, on the same time, a rumored outbreak of viral hemorrhagic fever in that country. And I'm so struck by, like, to me, that was a very compelling case for why it really helps to have good relationships in country, because in that instance, we have to make a decision about the threat to Americans that are there, the threat to Americans that are coming, as they come back, and needing to get up-to-date information about what's going on in order to make those decisions. It really helps to have those relationships, and not only those relationships, people in country to be the eyes and ears and tell us what's going on. And I think one of the things that I learned a while ago about CDC that I think differentiates it from other government agencies that work in global health is that a lot of the spend are on people. And so it's a recurring spend. It's the employment of people that are working day in and day out on behalf of American interests. Mm-hmm. It's not just a one-time purchase that you can decide, I'm not going to buy that this year. It's about, a sustained infrastructure that is continually, providing not only in-country benefits, but also benefits back to the United States.
And Jennifer, just to build off that is so important is the fact that we've been afforded the opportunity to be, we as the US, as CDC, be in rooms where normally we wouldn't be allowed. If I think about some of the, multilateral organizations where there's through a bilateral, you would not be allowed into a room, but being part of the multilateral, we've been in the room, we've been able to hear, but also add our expertise on advice and technical strategies and setting policies that not all nations get. And there's an opportunity there that will be lost in that sense.
Yeah, I mean, the cost of not being in the room when it happens, mm-hmm. Right? Jen, chime in.
I was going to say, I mean, my purview, a lot of these questions is from being in Washington and talking to policymakers and listening to what some of the arguments have been around scaling these things back. And they've ranged from, suspicion about international cooperation and feeling like the U.S. is doing more than it should, and then other concerns. We have to focus on what we need at home. Why are we spending money abroad? Those kinds of arguments. And I think it really there may be some validity to talking about how to scale back over time what the U.S. does around the world, and capacity has been built. So where we are right now with ministries of health in other countries is not where the U.S. was 20 years ago or 10 years ago. That is true. But the way I think about it is what has happened since January 20th has been such a kind of upheaval of the existing relationships and systems that we've had, whether it's the membership in WHO, the reliance of other countries on our expertise, the funding of different networks, that has been disrupted in such a way that it's one issue that's come up is countries can't rely on us anymore. They just it's not a stable relationship. But I also think about it from like a pathogen or disease perspective. When there's upheaval, when there's disruption, that's exactly when viruses and other pathogens can spread. And so you can't detect them as easily. The systems that are in place that usually can guard against them and quickly respond are not always going to be there. And we've seen from all this, the upheaval, it's been a ripple effect around the world. The U.S. has been the largest player. So when the U.S. kind of pulls out the rug, everything gets shaken up, and that's what's happened. So I mean, there's a valid discussion to happen about how to do this in a responsible pace over time. But I think what we've seen is a real just throw it up all in the air and see. Yeah. So that is purely from an epi perspective, that is quite concerning.
Can we talk a little bit about the pace? I know you've been tracking, Jen, the budget situation, and for those who are, they hear the headlines, cuts, but can you just like give us some specifics of what's
Yeah.
happening?
Yeah, so it's a little complicated because we're kind of in an unprecedented time. Some of the things happening have really not happened before. So there's many things, but two I want to highlight on the funding side. One is, yes, the budget, which people have probably heard about. Every president every year puts a budget request to Congress. And that's required, that happens. And then Congress decides whether, what levels of funding it wants to provide to different areas. That's the way it's supposed to work. It's a process that is always fraught with partisan squabbling. That's just the way it is. But generally, the president's budget request is not what Congress ends up with. Congress plays its own role. And many times, most times, Congress actually can't even really agree on a budget. And so we get into a situation where you might have heard about continuing resolutions or omnibus packages where funding continues, even if there's not really a good fundamental agreement. So you still get money. We don't know what's going to happen with the president's budget request. The president put out the budget request, and it, as I think you mentioned, Jen, in the beginning, calls for eliminating the CDC Global Health Center, no funding for global HIV, no funding for global TB, no funding for polio, malaria, all the things that CDC is an technical expert in. It does maintain some funding for global disease protection or global health security, but at lower. So it really would change the way in which the government has been organized to respond to global health threats. But we don't know what's going to happen with that request. Separately, and this is the complicated part, this administration has, even while that's going on, has just stopped spending money that it's already been appropriated by Congress, has just, canceled projects, RIFed individuals, meaning putting them on leave, and is already moving to not implement programs with funding that Congress by law has given to be to be implemented. That's not just for CDC, but that's everywhere. So that is a very unusual component of this, and one that's being challenged in court. But I just wanted everyone to be aware that both of those things are happening at the same time. So the budget process is going on. We don't know what's going to happen with it. Very well may be that Congress says we can't decide, and we're just going to fund the government at the same level. But the administration has its view is we can decide how to spend that money or whether we want to spend it or not.
Thank you. That's really helpful. And you mentioned this, Jen, before when you talked about PEPFAR and how it's useful for multiple things, but I want to maybe make this very, very clear. So let's say someone is like, you know what, I don't think the United States should be spending money on other countries' HIV problems, but I do think we should spend money on global disease detection. So just think through how that is. Disease detection happens when a sick person seeks some kind of healthcare, and there has to be healthcare infrastructure for that person. And then there has to be some clinician or somebody to think, maybe this person has something, maybe this person needs to be tested or diagnosed. And there has to be an infrastructure there in order to diagnose that person. Maybe they'll take a specimen, maybe get sent to a public health laboratory. That specimen has to be transported to that public health laboratory. That public health laboratory has to be able to test it. That public health laboratory has to be able to determine what it is and relay that information back, and then also, report that up. A lot of that infrastructure is built around vertical programs like HIV or TB or malaria, but winds up getting used because we don't know what a patient has when a patient shows up. So the idea of picking and choosing and saying, well, I only just care about surveillance, but I don't care about these other programs is just, it's a false premise, really. Confirm that's an accurate description and tell me more, because I don't think people realize how all these pieces truly do not only fit together, but actually depend on each other.
Yeah, I'll start, but yes, that's exactly right. I think in a way, it's a bit of an artificial distinction, the way that our programs get formed and funded. HIV over here, disease detection over here, and they really do, on the ground or in people's lives, those things intersect. And when the U.S. invests through PEPFAR or through a malaria program to bolster laboratory capacity, for example, or surveillance, that's a new structure, new capacity that is created in a country and is, not that it could be, is used for other things. During COVID, actually, PEPFAR was able to mobilize much of its infrastructure to help respond to COVID. So that is exactly the way it happens. And it does, it is a misunderstanding of how these things work on the ground, potentially, to say we're not going to fund that, but we'll fund this. And again, reductions, Congress, it's in their purview, or any administration to say, let's rethink how we're doing this. But in this kind of abrupt cliff, I mean, we're looking at a real cliff in the amount of funding that's been made available, is going to affect that capacity for sure.
Yeah, Rebecca.
Yeah, I'll jump in on this because you're absolutely right. These are vertical, but both Jen and I have said these same words: surveillance, laboratory, having the workforce, having emergency response. All of these vertical programs have this common foundation of needing these strong components. And what has been built with PEPFAR, what has been built through polio eradication efforts in countries, malaria, is really, all of these rely on one another. And, just going back to COVID, all of the diagnostic testing that was done through the PEPFAR labs that had been built in countries, especially on the African continent early on. If without them, there would not have been knowing what types of serotypes were circulating, to know what was coming through and what we needed to prepare for here in the United States. So it is all this built for. The workforce for polio responded to Ebola in Nigeria. We've seen this over and over again, where having this workforce that has been developed and strengthened is used in multiple ways. And it's not something that, the US needs to continue to invest in, but the country does. It needs to maintain this workforce. So once capacity is built, the sustainability of this is important, and they're able to use it for other areas of work and having a healthcare system overall. But it is really important about how the US engages on this, to be able to know what's happening and to be able to help also know what we need to be doing here in the United States for innovation and for diagnostics and for research, to be able to help protect the United States and the people.
We talked a lot about PEPFAR, and that's been in the news a lot, but there's also been a lot of questions about measles. The United States is currently experiencing the largest measles outbreak it's had since it eliminated measles. It's the deadliest outbreak in more than a decade. This is spreading domestically, but many of the cases that have been reported are due to travel. People have gone elsewhere, contracted measles, and come back, which doesn't make it easier to control measles. Can you talk, maybe Rebecca or Jen, whoever wants to chime in here, about sort of like the global measles infrastructure and CDC's role in that?
I can start, Jen, and then you can jump in. Okay. So again, this is something that, with the goals of countries and regions coming together, recognizing this is a deadly disease, that it does still affect people. It's not something that's gone, and now we have a quality product, a vaccine to prevent it. There was a large effort to say, let's stop this. I mean, if you go into hospitals, even in the late 90s, early 2000s, in many countries, there would be measles wards, or just be full of measles cases. And through work that's been done through vaccination, those wards were closed in the early 2000s. But this, again, has been, the CDC has worked with countries and worked with multilaterals to develop diagnostic tests, develop surveillance systems, reporting systems that countries agree to report into the World Health Organization, so you can know what's circulating where. And as you said, people travel all over, and this is one of the most infectious diseases. You can be in the room and leave, and with 6 hours later, somebody can still get measles if they're not immune to it. So this is a really, we'll call it the canary in the coal mine, so to speak. It's like, you can always know, if you have a system that can detect measles and can respond to it, you have a strong health system to be able to do that. But so again, with both the laboratory, the US CDC helped set up this network of global laboratory around the world, sharing both ideas, but also innovations to do that, the reporting of the surveillance information, as well as then conducting measles campaigns with the vaccines, to deliver the vaccines. And that's done through a huge partnership with many different, both private and public sector engagement in that, to be able to address that. But as we know, there are populations in the United States that are not immunized or cannot be because of immunodeficiency diseases. And if people travel, they go on their high school trip, they go on abroad to travel, they bring it back. And within communities, then it is spread and it will find everybody who is not protected against it. So it is a really serious threat. And it is something that there is a strong network set up, both laboratory and surveillance. There's a good vaccine, and we should not be seeing outbreaks, and especially we should not be seeing deaths of measles in children in the United States at this time.
Yeah, I actually think measles is probably the best example to make this a little bit more concrete for people right now, because the reason we're having an outbreak in the United States right now that is more severe than any and may actually threaten our measles elimination status is because of imported cases combined with low vaccination, lower than normal. So it's not that we still have a high vaccination coverage compared to some other countries, but it's lower than it had been, particularly in younger kids who are vulnerable. Kids can't get fully vaccinated against measles until I think 5. So young kids are what we're really talking about for a very vulnerable population in the United States. The outbreak is happening because imported cases come in, exposures happen with people who kids who can't protect their immune system yet, or their parents don't want to get them vaccinated, and adults as well. And almost all of the cases that have been spreading in the US are spreading among unvaccinated people. And people have probably seen stories, somebody who doesn't realize they have measles, feels a little sick, gets on a flight, goes to Dulles, then gets on a train, goes from Washington to New York. That's how disease spread. And you just multiply that globally, and we see this is the exact reason we want that kind of infrastructure. So it's a complicated dynamic, but that is exactly what is happening right now.
Yeah, and maybe I'll just add to that, because I think when you look at the overall coverage, like MMR vaccine coverage for the United States, you know that it's lower than it used to be. But it may not look to, just kind of an average eye as like, well, it's not that much lower. It's below the target that we need. But that really like hides the fact that in communities in the United States, the coverage is actually, there are some communities where the coverage is very, very low. And so these little pockets are where, you can really have these like explosive outbreaks. I mean, measles can cause explosive outbreaks anyway, but when it finds its way into these communities where the vaccination coverage is really low, the probability of finding someone who is not protected is high. And therefore this thing just accelerates really, really quickly. So we have a lot of points of vulnerability that you don't see when you look at the overall coverage in like at the country level, across the entire nation, or even at the state level. And that is why we're seeing a lot of this happening now, combined with this breakdown. I also want to talk about okay, so we're talking about here's the things that we could lose, the capacity to lose, but can we just play out some other scenarios? Like, what are the things that could happen here in the United States? Like, what worries you about what will happen, some of the disease scenarios? I mean, I think, people hear PEPFAR and they think, well, it's very sad. People are going to contract HIV. They may die, but that's another country's problems, not ours. But talk about what it could mean for the US, what the breakdown of some of these systems for preventing, detecting, and responding could mean. And whoever wants to chime in first. I forgot where we are.
I'll jump in first, Rebecca. So yeah, I mean, HIV specifically, HIV is in general well controlled in the United States right now. For most people, not everybody, and globally much better than it had been, and that's largely due to the United States actually. However, when HIV treatment has been disrupted, we know that's a fact, and a lot of the systems that are globally that provide HIV services to those with HIV and prevention services to those who are at risk have been disrupted. There is a real risk generally when if we're going to see a rise in cases, a rise in deaths, a rise in potentially resistance when people are not able to get treatment. So that does have implications for the United States. But where I do get fearful or more concerned is for potential outbreaks of things that are highly infectious, especially, and also mostly about if there's something novel, like something that we haven't experienced before, like a COVID scenario, or worse, because COVID ended up not being as infectious as we didn't know in the beginning. If that were to happen, and we were faced with another outbreak at a serious level, I worry that our systems in place in the United States, at our borders, and in the robust systems that we've built with other countries are just not secure enough to respond in a timely fashion. And that would have obviously very grave implications for the United States. I also, we can't divorce politics from this. How we respond to disease has always been political, and it would be political again if there was another serious outbreak or pandemic in this country or around the world. And that factor will probably have more to do with the response or the lack thereof than anything else. So I think it just, as Americans, we should be thinking about this and understanding that there are limitations at the moment to what the infrastructure could do.
And just to, I think to add to that is, it's what I worry about too is, us not, the Americans not being in rooms where we would learn about information, we would learn about the detection of a certain virus or certain symptoms that were a little bit off, but we wouldn't know about that until it's too late. And as we know, people travel all the time, coming and going. Americans live abroad as well. And so there is always that threat, but not knowing and not being able to prevent or to be in an early preparedness response stance is really critical. And as we've seen with reductions in workforces within the US government, as well as people leaving, I worry about us not having the experts anymore as well. That people are leaving or have been asked to have been reduced in force, so that we know as well that we may not have those experts. And that keeps me up at night too, worrying about how are we going to find them, how we're going to reach them, and make sure that we know about this. As well, I mean, CDC is a national entity, and in each of the states there are public health laboratories too, and states are being affected. And I think this is the other thing, is within this, it's the whole public health system of the United States, and that is critical. That is there to protect every American. It is not just for one certain target group or certain population. It is there for everybody. It's why we can drink water from our faucets. It's why we can, have different things that would normally bring disease. And so by doing this, we are disrupting the infrastructure that has taken decades to build, and the people, the knowledge that's there as well. And then being able to set policies to help protect, global policies to help us protect Americans as well, is the third component of that will be really, it could be very much affected as well as damaged.
Yeah, I mean, Jen brought up this point about being in the room early to figure out what's going on, particularly to figure out if something unusual is going on. Jen brought up the whole, the novel next pandemic, but also deliberate or accidental releases, and the security element of this. It reminds me of your the points you opened with, Rebecca, when you're talking about like CDC was, the formation of CDC around malaria, and like US overseas interests. We have businesses, we have military personnel, the control of diseases in settings abroad bolster US interests in those ways. Can you speak a little bit about the private sector element to this, like what this could mean for private sector? I think a lot about 2003 during the SARS epidemic and the US financial sector that had a very strong personnel, they had a lot of personnel in the countries where SARS-1 was spreading in 2003, and that was, directly affected them. But can we talk about a little bit about other, private sector interests?
No, I think this is critical. It's any American living abroad, and as well as these companies. And it was early within CDC that companies recognized that they needed business continuity plans in case of epidemics, in case of outbreaks or pandemics. And they turned to the CDC and said, can you help us put these business continuity plans together? What's going to be affected? And that sharing of information back and forth about what they were learning and seeing in countries, and also what CDC was seeing, so that they can also protect their workforces in the countries needed for their trade and commerce, was really critical. They are an important point and important corner of this relationship in protecting both the national security and health security in this sense. And it's so valuable that there is that opportunity to share information, but as well as that CDC provides information to them for developing plans of, like, if this is going to happen, you could lose this X% of your workforce. This could shut down this. When we know that ships cannot get to ports to deliver materials because there's been a ban on entering the country, and that is going to affect their business and their profit and their budget line day by day by millions of dollars. And so that information is so critical. In addition, with the health security agenda, there was the bringing in of the private sector to help, bringing in that they could innovate quickly, they could have flexibility. So in addition to they were component of the health security, of the global health security component, recognizing that through them, we could have access to quickly diagnostics, to tests, to vaccines, to drugs that would be needed, protective equipment, that they were an important partner in this. And so they do see the value of this, and knowing both for their own businesses, but then also in thinking about the larger what's needed to protect the world and to protect the United States.
Jen, anything to add, or
No, I think I totally agree. I mean, the private sector has been a partner, but I think after, the COVID experience, that they're very well aware of the potential impacts on their bottom line and their workforce and their enterprise. So whether it's airlines or ships or workforce or, shopping, people, I think there's a much greater awareness now of how that can be affected and disrupted by an outbreak in our country and elsewhere. So that at least I think we have that greater knowledge on the part of the private sector.
I see some questions coming into the Q&A box, so I'm going to turn to those now. And the first question is I think the question is around what can we do to fix this? It's about reversing the process. Any tips? Maybe Jen, you've been more active on the Hill front. What would you tell people who are listening to this horrified and now want to know what to do to fix it?
Well, that is a very good question. There's a lot happening at the same time. Jen mentioned that there was this larger process of dismantling USAID and a foreign aid review and sort of taking that infrastructure apart. There's also what's happening at CDC and other parts of HHS. One of the ways in which there's been pushback has been through the courts. So challenging some of these steps. And there's been some cases there has not been success, and others there's been limited success or temporary success. So that's one. And we track that a lot of that litigation, as do others. So that's one. The other is, the role of Congress. Congress really is the power of the purse, and Congress really is supposed to be where the decisions about the amount of money that the government is spending get made. And so I think a lot of people are looking to see what is Congress going to do now that all of these things have happened in quick succession. Is Congress going to push back? And we've seen some of that, but it's not clear. And then I think the third is, as with everything global health, civil society has been a kind of a key component, both in promoting global health efforts, but also in calling for ends to some of. There's a large advocacy effort in DC and other places to try to counter some of these things. So there are these pieces happening, but it is the scale of and the pace are very large and fast. So it makes it difficult. I'll give you an example. Even if the courts ultimately say to the federal government, you can't dismantle USAID on your administration. That's the purview of Congress. Well, it's already been dismantled. So it's happened. It happened quickly and things like that. I mean, I think that's so. A lot of the conversation in Washington is also turning to what to do. What should we look ahead at? What's the new global health response going to look like? What can we move on from this point and try to be as robust and thoughtful as we can? And so, that's not maybe a great answer, but those are the components that I see.
I would just add to that. I think that's absolutely right. I mean, people have asked me too, is, well, can we go back to what we had? And I don't believe that we can. I think this is a new day for global health. And it is a new figuring out of how we're going to work in this, what we're going to do, and it's going to take coming together to do that. One thing I have seen going to Washington and talking to is, again, the awareness of what was happening, and not being aware of it, to be honest, knowing what it was doing and why it's important. So sharing that information about why is it important to people in Ohio, to people in Kansas, that we have this and what is being done is so important. For why CDC works globally. And I think these are really important messages, and the continuing education and sharing is just has to be an ongoing process for this. It's not a one time you go up, you're done, and you've talked to or talked at your state level. It has to be a continuous dialogue about this, about the awareness, and speaking out about what's going to be lost if there's no global immunization at CDC. If PEPFAR is cut and the risks are increased even more with the budgets that have already been cut. So I think this is really important in showing the connection of the global to the domestic, and why this does impact American people is really, really important at this point in time.
And I think it's also important to make the case, particularly people to their elected officials and others, that this matters. And we know that it matters to the American people. I mean, all the polling on this suggests that there's very high support for things like immunizations, for global programs that keep Americans safe. And to remind the people who are, in the room to make decisions about these programs, to the extent that the decisions can still be made, that these matter, to keep that on their agenda, because there's a lot of things that they're dealing with at once. One of the things I'm concerned about is that helping people recognize that these are not just like light switches that you just switch it off, and then, a couple years later, when we have a change in political winds, we decide to turn it back on. Like, some of this stuff will not be able to be rebuilt. And there will be a loss associated with that. I agree that going back to where it was is probably not a likely path. But it isn't just the case that were we to wish for it, we could just simply turn the lights back on and suddenly the programs are going to kick into place. The time is now, really, to prevent as much damage as possible. And part of that, I think, is just for people to remind elected officials, et cetera, that this is actually very important to us, as the polls repeatedly show. I think something to remind is that this is something that the American people generally are highly supportive of. Go ahead, Jen.
Yeah, Jennifer, I think that is so important. And here in Georgia, with people being, asked on administrative leave or positions abolished, these are the state's constituents as well, and they are adding to the economy, and it does impact Georgia's economy as this happens. So there have been discussions too about how to reach out to the Atlanta or the Metro Chamber of Commerce, and to talk to elected officials here, state officials, about this, and the value of CDC in Georgia, what it contributes, both individually but also to the world. It is so important. So I wanted to reinforce that point that you made on that. Thanks.
Jen, you were going to come off mute before. I'll just say I'm emphasizing the polling piece because there's been a lot of polls, and I know KFF does this, Jen, so maybe you can chime in about like public support for immunizations, measles, for instance, MMR immunizations. It's high. It's the majority of Americans. Yes, there are slight differences according to political affiliation, but it is still high across the board. I say that because some of the justification used for attacking global programs like immunizations has been supposedly done in the name of restoring trust, when in fact the polling shows otherwise. The trust is quite high. People support these things. They think these are valuable tools. They think there is a moral obligation to provide this, to make these things available low cost, et cetera. So I just wanted to emphasize where people are. And I think, elected officials, if they just read the headlines, might feel otherwise, but the data show that this is something that the American people support.
Definitely. I mean, our polls have shown that consistently, and we continue to ask. There are partisan differences, and I think this has become much more polarized than it ever has been. And so that's an area where that's getting worse, frankly. But majority of parents, for example, say, yes, we want to get our kids immunized. We support immunization. That is still the dominant view across most of the public. But we're tracking it because we know that what happens with what the federal government does and says globally or at home could impact that. And could start to drive down that support or trust in different ways. But yes, right now there is support. We also the American public supports, as you said, responding to infectious diseases. People are worried about infectious disease. That's an area they don't think that should be cut. They get that there could be something at risk for them if that area is cut. So I think one of the challenges for public health and global health is that it's different than somebody in the United States going, don't take away my Medicaid or my food support, because that's a very real, concrete, daily household need and thing. And public health and global health, that's always been much more distant to most of us. So it's been a harder case to make. But it is, again, I'll go back to when things are working well, we don't know what's happening. It's all happening in the background. The systems are doing what they need to do. It's when something breaks out that we have to hope that we have a robust response.
And Jennifer, you hit on a really important point about shutting these systems down and restarting them. It does not happen overnight. And we rely on these ongoing systems to be able to respond when there is an epidemic or pandemic that you can scale up and that you can reinforce, flex the muscle, so to speak. And thinking of an example of seasonal influenza vaccine, you can't just start making, flu vaccine if you have no manufacturers making seasonal flu vaccine within that time frame. So the need to have these ongoing systems functioning is really critical so that you can rapidly ramp up when there is an outbreak. It's the same with the workforce. They do this, in terms of preparedness for disasters as well, as keeping that workforce ready so that when there are those events that they're working day to day on things that are happening, but then when you have those outbreaks or emergencies that they can quickly scale up. You can't pull them out of a catalog and say, I want 3 of those and 2 of them. I mean, you really have to keep that momentum in the workforce going.
Thank you for bringing that up. I was reflecting on this from a domestic situation. I had been involved with a study looking at the U.S. response to measles outbreaks that were happening in 2017 to 2019. And one of the things I was really shocked when we talked to states is that they really were not doing much by way of contact tracing. We talk about contact tracing as being like a bread and butter public health, and they weren't doing it. And part of why they weren't doing it is that systematic cuts over the years had meant that they did not have the resources anymore to do contact tracing. And for measles, that's a very compelling case and highly contagious disease. You really want to understand who someone who was infected may have exposed so that you can prevent the spread further. But they weren't able to do it because the cuts had been made, the staff and the infrastructure wasn't there to do it. This was 2017 to 2019. What happens in COVID-19? Suddenly we're like, we need to do contact tracing. And then suddenly you're faced with having to spend a whole lot more money to hire in a flash contractors who are not trained, not experienced, haven't done this work before, try to drop them into a system, try to get them integrated best they can and scramble to do it. And it just doesn't add up to what would have been had we had that infrastructure maintained in the past. I'm hearing, when you hear about some of the federal officials who've been let go because of the RIFs, the reduction in force, and then realizing, oh, whoops, now we're in an emergency. We need those people. Let's go try to hire them back. How hard it has been to get those folks to come back. And thinking about the global health workforce that had been US funded and letting those people go, I'm thinking if there were an emergency, we would find ourselves once again scrambling and have no choice but to pay more for what ultimately amounts to less than had we maintained that infrastructure and investment instead of cutting it. Anyway, I just have to make that point because I think we don't realize, these single use, just purchased in a time of emergency solutions just never wind up being that kind of, we pay more for it in the long run. There's one more question here that I want to get an opportunity to answer. It's a little bit topic, but I think this is an important point to kind of maybe focus on from our last question, which is Given the current dismantling of public health and the backlash against non-pharmaceutical measures like masking and social distancing, the politicization of public health measures, and views about vaccines, how would we protect populations during an emerging pandemic before a well-matched vaccine would be available? And maybe I will just caveat that to say, if a well-matched vaccine is available, I think we have a pretty good shot if it's flu, but if it's another infectious disease, may the science fall in our favor, but we shouldn't always count on it. I think we got a little spoiled with COVID and how fortunate we were that the science worked out. But any thoughts on this? I mean, this is my, and I'm going to say, this is my fear. I think we are in a different place than we are now. And honestly, if for anyone who's thought about deliberate biothreats, thinking about how the United States would protect itself in a deliberate attack, this question really keeps me up at night. But any thoughts on that? I don't know if there are answers, but
I'm with you. This is my nightmare scenario. I think that what we saw in the beginning of COVID, because it was most people had not experienced something like that before. People were willing to listen to public health officials, even at a time when we didn't know. People did the best they could. I don't think we'll have that again. So great question. Maybe there's somebody out there who knows a good answer, but I am definitely worried about it.
And I think too, this it's true, and it's sort of what we learned during the COVID pandemic was, as information was gained, decisions were made based on that information. And then as more information was learned, it was like, okay, maybe we don't need to do this, we need to do that. But how that's communicated is so critical, because if you don't communicate that in a good way, it's sort of like, well, you said this and now you're saying that, and you're not doing. So there can be a lot of opportunities for sort of misinformation in a way, not on purpose, but misinformation and understanding this. So the communication is really critical, and this is something we have to work on. Of course, it depends what the pathogen X may be, of what we need to do, what measures, but I think that will be really critical, is the communication. And just as we talked about, having that continuous work in these areas in surveillance, contact tracing, we need that in connections to communities too. And how we do that through community-based organizations, civil society, but having those relationships of who's going to be the best messenger, best on what going to need to be the intervention, will be really critical. So I want to add that sort of facet of this as well, which is the communications and how we bring in civil society and who are going to be the influencers. But as to what's going to be done, I mean, I think this is exactly right. It's like, how do you reach people? How do people understand the risks best, and what measures they're going to take individually, but what we need to do them as a community as well to protect others and their families. So that will be, I think, really critical in the next sort of pandemic as well.
yeah, I absolutely agree. I mean, I do think we have to have the conversations about what we should do, what we would be willing to do, what we could do. I don't think it is acceptable just to systematically take every single option off the table. Listen, I am someone who at the start of COVID-19 did not think we should close schools. I was opposed to closing schools at the beginning. Let me tell you, if a deadly disease is killing kids, that's just not something you can just absolutely ignore. We need to figure out what we would have to do in order to protect children, but also make sure they continue to learn. There are questions that need to be answered. I do, to your point, Rebecca, think that preparedness is a bottom-up exercise, and we do need to have these conversations in communities. So I think for anyone who's listening, who is thinking, this is hopeless, the world is imperiled, we've shut down all these programs. Yes, we have a lot of reasons to be worried. That said, I think there are powers in communities coming together and saying, what are we going to do to protect ourselves? What are we going to do? Engaging with civil society, engaging with businesses, walking through a few scenarios and saying, if this were to happen, how could we protect ourselves? Recognizing that some of the larger systems that we may have once been able to depend on may not be there, and there we're going to have to fill in the gaps. I want to make it clear, filling in the gaps is not going to add up to what it might have in the past. There is no replacement for a nationally coordinated or globally coordinated response. There is no replacement for that. But it doesn't mean that all is lost in terms of there being no options. And I do think communities can come together and say, this is still important to us, and what are we going to do to be able to care for ourselves? Okay, any last thoughts, anything? All right.
I just, can I
go
just,
ahead.
I would just say that the American people need and deserve a strong science-based, evidence-driven CDC. And I know CDC staff and people are so committed to working 24/7 to protecting the United States and the people, as well as then how to prevent diseases all around the world. And they're poised to do this. So I think the ACIP meeting that happened this week, I saw that the head of the American Academy of Pediatrics said, we're just ignoring this meeting. And that to me is already one big signal, is like when you have bodies ignoring CDC, that there's something wrong here, and we really need to figure out what we're going to do here and fix this, or figure out how to go forward from this. But you can see CDC's work in every state and around the world, and people depend on this. Thank you so much.
I have one
And
thing to
just-
add to that,
oh,
which just
please,
because
yeah.
you brought up ACIP, and I watched both days, and I've watched lots of ACIP meetings. And one of the things that just to support what you said, the expertise that CDC officials bring to those discussions is amazing. So there was a lot of other kinds of discussion, but the preparation and the CDC representatives who were presenting on the science, it was quite stellar and quite amazing to be able to learn from them.
And I just want to say that the polling of the American people in terms of what they want from the CDC centers on CDC being able to provide them with sound scientific evidence. That is what people, when asked what you want CDC to do, it is providing that scientific guidance and evidence. Okay, well, thank you. I really am grateful to you both. Want to extend my sincerest thanks to our panelists, Dr. Jen Cates and Rebecca Martin. I also want to thank everyone who joined us today for this discussion. I also need to give enormous thanks to my team at the Pandemic Center who helped put this event together. Bentley Holt, Michael Mitchell, Leah Lovegren, Amanda Kogan, Carly Gaska, Andrea Ulig, Ann Wang, Alice Im, and Brendan Bang. For anyone who's listening, if you want to stay up to date on future sessions, there is a QR code on the screen that you can use to access our Linktree, and there you can sign up for our webinar mailing list, catch up on past recordings, or explore other resources like our weekly tracking report. A recording of today's session will be available on the events page of our website next week, along with all of our other previous webinars. And please follow us on social media for updates or to reach out with any questions or suggestions for future sessions. We always love to hear from you. So with that, thanks to all. We are adjourned. Be safe, be healthy, and stay engaged.